Talofa lava, I'm Jacqueline, and I've taken this opportunity to present PhD research study. I'm the one and only CMH Research Fellow that got awarded funding in 2016. So this is the first time I've actually presented to counties of my research. So, and as Don mentioned before, I've got 2 slots, so I'll be using the whole 20 minutes. So the overview is, the first part of the talk, I'm going to just give a very brief rundown of what my study looks like, the research design, and then I'm going to present phase 1 study findings, which is the context within diabetes self-management, and it's a realist evaluation. So the rationale for my research was, why do Pacific people with diabetes end up dying from renal failure? And with all the services and interventions in place, why do they still keep dying from renal failure? From this point forward, I'm going to use we instead of Pacific because I am Pacific, and I want to really hone in that I am talking about something that matters to all of us. It's not just a subset that is them, there, so I will use we instead of Pacific. The issues are that compared to non-Pacific populations or other New Zealand populations, we have higher diabetes rates. We also have higher rates of comorbidities, where 1 in 3 Pacific adults of 45 years and over have diabetes complications, and it's more than one complication normally. We have 11 times higher incidence of diabetic end-stage renal failure. And with these and with end-stage renal failure, we're also likely to have CVD and or foot disease and or retinopathy. All of these complications make it really hard to manage all the comorbidities. Now, those are the issues, but the problem is that Pacific have really low engagement in self-management of their diabetes and of the other illnesses. So to find out what's going on in the system, the primary research question from my overall study was, what are the factors that influence opportunities for Pacific people with type 2 diabetes to engage in the self-management of their illnesses? Or looking at it another way, I want to understand the contextual factors that affect diabetes self-management of the illnesses. And by investigating this, can I identify opportunities, which are the critical points, that can delay or prevent progression? Now, when I say delay or prevent progression, I'm looking at this using the pathway from diabetes to end-stage renal failure. I'm going to look at it prospectively, or I'm going to look at the progression from diabetes through to end-stage renal failure, and I'm also going to look at it backwards, retrospectively. The study perspective, I'm looking at 3 different perspectives, and it is a systems-based perspective. And I'm using self-management philosophy, which is part 2 of this talk. I'm using the risk trajectory of diabetes illness amongst Pacific people, and I'm looking at patient experiences. The study design, it looks quite complex, but it's quite easy. It's a sequential mixed method study. Now, normally in mixed method studies, you have two studies. I've got 4. Each individual study answers the overall research question. In the first study, phase 1, which I'll talk about soon, as I've already alluded to, it's how does self-management work? And the next study, which I'm currently in the progress of wrapping up, and Chris Hood is going to be part of that analysis, is I'm doing descriptive statistics where I do logistic regression modelling, and I stratify Pacific by 7 different ethnicities and look at their risk trajectory for end-stage renal failure. In the third study, it's a focused ethnography. We'll actually go out and interview patients with end-stage renal failure and ask them to look back. That's the retrospective side. Knowing 1 on 2, how did the system and how does your clinical factors, how does that work for you in your world, in their world, in the real world? And then the final part of the study is phase 4, called a parallel track analysis. And that's when I bring each individual study together, synthesize the results, and answer the overall research question. Each research phase has its own research questions, and that's because congruence of methodology. As we all know, when we're doing methodologies, the methods and the way that we're going to conduct the research, they have to match. So I've got a research problem that is both objective and subjective, positivist and interpretivist, or quant and qualitative. My research questions have to match that, and also the study methods also have to match that. And looking at the underlying theory or the underlying perspective that I'm coming from, I believe that, yep, things do exist, but I also know they exist outside of what I can see. The study philosophy I've chosen is critical realism, which is a really good method for, a really good, theory if you're doing mixed method studies. And finally, the study timeline. I did start in August 2016. I'm currently almost into 2 years, and I've got a long way to go, but only a short time frame, if you know what I mean, until I hopefully hand in 2019. Okay, so that's the end of part 1. So that was the brief fly-through my PhD study. The next part of this session I want to talk about is phase 1, and that's context within diabetes self-management and realist evaluation. I'm going to fly through this as well because it is quite complex, but if you want to know more, this is the article that's still in press, but it should be published in the Diabetes Clinical and Research Practice Journal next month. I'll go through the traditional introduction, methods, and key findings and conclusions as a format for the study. So a question is, how can you evaluate, critique, criticise an interventional program if you really don't know how it's supposed to work? What's the underlying theory of it? How is it constructed? I'm not talking about the outcomes, I'm talking about how is it constructed, how is it supposed to work? So the aim of this phase was to evaluate how contextual factors affect diabetes self-management and examine in what way these factors affect self-management effectiveness. In this study, I conceptualised self-management broadly to be a program that incorporates self-care and self-management support. And I focus on these 5 common daily tasks for blood glucose management: medication adherence, appointment attendance, regular exercise, eating appropriately, and glucose monitoring. Now those 5 daily tasks, the ADA, American Diabetes Association, and New Zealand guidelines and other critical literature have put them at the top as the 5 daily tasks for blood glucose management that you must do in order to manage your blood glucose. For data collection, this was part of my literature review, but rather than just doing a literature review, I decided that I'm actually going to do something different. I'm going to put a realist evaluation on top of the literature review. So the literature I chose were primary intervention and observational studies looking at patient experiences with type 2 diabetes, with those 5 daily tasks as a focus. The evaluation was a realist evaluation. Now, that's a theory-driven appraisal of understanding how the system works. It doesn't look at the outcomes. It asks what works for whom and in what circumstances. And in the model, you begin with initial theory. What's the rationale behind self-management? What is it? How is it supposed to work? You then come up with a hypothesis for what you're looking at. What do you think will happen, or what will happen, or how do you think it's going to work? The observation, what is seen in real life? And then at the end of it, you come up with the actual specifications for, in this case, self-management, what works for whom and in what circumstances. So my initial theory was that self-management is an effective program for managing diabetes. We all know that. That's all health professionals, all health workers, that is the program, self-management for effective management of self-diabetes and other conditions. So my hypothesis was self-management, what might work, effectively helps all individuals with diabetes, for whom, regardless of socio-economic status. All individuals, regardless of who they are and where they come from, and that's what in what circumstances. Realist evaluation uses context, mechanism, and outcomes to help explain what's going on in the system. And in this case, mechanisms act like triggers to trigger the outcome, and the context and the outcome are pretty self-explanatory. The facilitators of self-management included access, ideal communication, support from family, and experience of comorbidities. Now, I've circled experience of comorbidities because a lot of contexts can also be barriers or facilitators depending on the circumstance of the person. There are more key barriers than there were facilitators. Financial constraints and work commitments were the main two key barriers. And if you think about it, all this list here, work commitments, time constraints, financial constraints, low confidence and self-efficacy, they all have a interrelated relationship with each other, and they're all bidirectionally related. That means that one causes the other and it goes back and forth, round and round. You can't get away from it. It's just like an ever-going circle. Now, since I view things in diagrams and images, I constructed a concept of those equations. And in this construct, you can actually see the triggers in the context of how they force one outcome, how they produce other contexts. And I've divided up into affordability and affordability and unaffordability. And if we notice with the unaffordability, which I've highlighted, regardless of barriers, we're still getting some health outgains, some positive health outgains. We have to, because we've got people out there with diabetes and end-stage renal failure. But what this says is that the system isn't doing so well at self-management. In managing blood glucose levels through adherence of the 5 daily tasks, while the context is affordability, the key issue is that coping with diabetes is outside the remit of the health system. All these issues I've highlighted in the green, they're outside the remit of the health system. The doctor in the GB practice can advise their patients what to do, but they can't give them more money, they can't give them time off work, they can't even help with babysitting so that people can get to their GP appointments. And in conclusion, these findings do not invalidate the current or continued practice of using self-management. However, we have to pay attention to what works, for whom, and in what circumstances. Furthermore, the implications are that all stakeholders need to work together. All agencies, health, justice, other social agencies, they all need to work together if we are to use such findings in order to produce a better healthcare system and redesigning or existing programs or interventions. Thank you. Was that 10 minutes?